All right. Greetings. So if any one of you want to receive a CME from MD Anderson, I suggest that you could register and you'll get a free CME for every session you attend. It's a 1 hour CME and it's fairly simple. All you have to do is register, and then once you come to the session, you send a text message and it will get registered for the event, and you'll have a CME for that. All right, so this is a patient that I took care last week, and I wanted to present this story. This is a woman in her 60s, late 60s, and she was referred to me for a resection of a proximal ascending colon cecal serrated polyp. And in addition, she had a resection of a small polyp in the cecum, and that was removed by snare. And there was another polyp, 10 millimeters in size, again flat. And the endoscopist made a comment that he was unable to resect it despite multiple attempts. And when I talked to him, he said, I just could not get my scope down between the inner lip of the IC valve and then down into the cecum where that polyp was. So that was a second polyp that was not resected. And there was another large polyp, 20 millimeters in size, in the proximal ascending colon, and he wanted us to help him. And he also made a note that the patient had severe diverticulosis, and she had at least 2 surgeries, one appendectomy and another one was tubal ligation. She was in good health, and except for a little bit of anxiety and hypothyroidism. So what I'm going to do is I'm going to share with you the video, the first video that is showing the lesion that he wanted me to resect. And in this session, we're going to not talk about resection of that lesion, but I will present that for our group to comment on what they think about that lesion. All right. Selvi and Sylvia, any one of you want to comment on this?
Please, Selvi, go ahead.
Okay, so thank you. This is a flat looking lesion that is looks like one full distal to the ileocecal valve. It's got a mucus cap on there, so suspect that this might be a cecal serrated lesion. That's it. Sylvia, anything to add?
Yes, I very much agree for the location, and indeed it's a pale lesion with quite unclear, indiscrete borders and cloud-like appearance. Maybe if we get closer, the upper part on the left side, we see some dark dots. And of course, as Selvi mentioned, there is a mucus, a very thin mucus cap. So this could be indeed a cecal serrated lesion.
All right. Roy, any comments?
It's SSA until proven otherwise.
Okay.
But you need to get rid of the mucus and then see if there is any dysplastic features.
Okay, I think that's good. So when you think about dysplastic features by looking at a lesion, when would you think that this is not simple, straightforward SSA, but it is SSA with dysplasia? When would you think about that? What features?
It's actually quite simple. If there is any findings of like an adenoma, sulci brain-looking mucosal pattern, that for sure is a dysplastic SSA. If there is any depression that would be like a neoplastic, like in the in the flat NPCRN findings, I would be very concerned that it's already transformed even further. Looking at the other features of deeply submucosal cancer can be helpful, because the SSA, when they become cancer, they basically go through that transformation. Now, having said that, the dysplastic SSA sometimes could occur only in a few glands. So when you have like 3-4 crypts that are dysplastic, then the endoscopic feature is very hard to find. So those things I usually would miss, but the others I could predict. In this lesion, there's very interesting that on the surface, if you look closely, there is that star-looking area that could be like a more depressed area. So I would be looking at that.
Okay.
You see that?
Right. You're looking at in this area?
In the go there and then go towards the top, the center there. Yes.
Right.
What is that?
We're going to come to that next week. So you need to show up next week also to see that story. So the reason I wanted to just present this is to just give you a story. And as I go into the cecum to see what other lesions are there. So I just, for the sake of time, I said, okay, this is something that we could talk separately next session. The other thing is, as when we are here, and as we are talking about the presence of dysplasia or not in a sessile serrated adenoma, one of the things that I would like to make a comment and I would like to hear from others is, although people are suggesting that you could do cold snare resection, it is very easy to resect sessile serrated adenomas with cold snare. There are two problems with cold snare of sessile serrated adenoma. One is if you are not sure about the margin and you don't define the margin well, you will leave tissue behind. That's one. The second is when you leave tissue behind, the next time when you come in to resect, it will be very hard to resect because it's not going to lift well. That area becomes tethered to the wall. So that's one. The second one is what Roy commented on is whether there is dysplasia or not. And I think it's a very important point to keep in mind once you wash off the mucus to look for whether there is a SSA plus an adenomatous component, like a tubular adenoma, tubular villus adenoma like features. In that case, I urge you not to get your cold snare and resect. Consider to stay away from that and then do an EMR with the injection and cutting with a hot snare. Otherwise, what will happen is you may cut superficially and you may leave tissue behind and it will become a bigger mess. And unlike a tubular adenoma, SSA with a dysplastic component is likely to go faster to cancer. So having made those comments, I want to hear from our group what they think. Roy, Sylvia, Selvi, why don't you just comment on what I've said?
It's very dangerous to ask me about cold snaring because I believe that anything in life that's done thoughtless is not going to produce anything good. So doing this thoughtlessly using cold snare will not be a good idea. It's big. You need to orient it. It shouldn't really be cut into like a corned beef. So all of these reasons. And besides, we can perform an EMR with good results. In fact, Raju and us had published a result like that, whereby we showed in clinical gastro that the results of doing EMR for this type of lesion is very, very safe.
Okay.
Maybe a quick comment.
Yeah, please.
I think that in the beginning, it was when we didn't have the EMR techniques, we didn't know about that. I'm talking about 2 decades ago. We couldn't capture these lesions. So I think it's even wrong to attempt to remove such lesion by using cold snare. Because as you mentioned, as Professor Raju mentioned, not even the borders will be unclear, but you will not be able to remove it because it will not be captured in the snare. At least this is my experience.
Yeah, that's right. That's right. I just wanted for the sake of trainees, I think it's important to make that point. So I just wanted us to discuss that. Okay, let me take you to this. Okay, we go down. So we go down to the cecum, and I wanted to see what happened to the previous resection. Do you think it was just a scar, or is there anything else there?
There's residual there, about 6 millimeters. So
Mhm.
Okay. Let's go back and see. I want to go back. Okay. So what I decided was I thought that there was a residual polyp, and I thought that maybe I should inject and remove. And what would you guys do when you see a residual polyp like that? Would you do just a hot snare straight, or would you try to inject and cut it? And how do you deal with that?
it's in the cecum, so it's best to inject and then use a small snare to cut it hot.
Okay. Sylvia, what would you do?
Yes, I would
Sylvia?
inject. I would inject for better visualization and for safety reasons. I would inject.
Okay. Sylvia?
Agreed.
Okay. So we decided to inject. I tried to inject saline with a little bit of methylene blue or indigo carmine. And this is what happened. Just 1 second. Okay. And one comment I want to make is when the endoscopist outside tried to do the resection, he did mention that he had a very difficult scope insertion to the cecum, and he used just a hot snare for resection. and he was not able to see the second lesion between the IC valve and the floor of the cecum. And one thing is injection of these lesions with prior cut are not easy. They tend not to lift like you wanted to lift. So in that case, you want to keep your injections point of entry away from the scar as much as possible, so that you can get a little bit of lift. As you can see, the lift was not necessarily satisfactory. So as you can see here, it was much easier probably to cut without injection. And now that I injected on both sides, I have two blebs of similar size and with the polyp in the middle. And in that case, what I try to do is I go in and try to use my cap to engage the polyp, and then try to suck that polyp into my cap to create a little bit of a pseudo polyp. That way, when I get my snare out, I'm hoping to get the entire polyp into the snare. So I try to do this. Let me ask Roy, how would you do this? What would you do normally when you have the problem that I'm facing?
I think you're doing a good job. You just need to have you have to make sure that you're using a stiff snare now.
Right.
So with snare open at like 10:30 down, we'll get it.
Right. So we're sucking and now, okay. So I bought it's actually very interesting since the Olympus came out with this cold come hot snare. Almost every week I end up with a problem. That is, I ask for my hot snare and the technician takes out a cold and a hot snare, and they don't even realize that they picked up a cold come hot snare, which is not ideal when you want to cut a polyp like this. Have you noticed that problem, Roy?
Yes. So I don't use it. So now you would need to APC it just to maybe towards the center of the scar. There's just a little nodule there.
Right here, right?
Yeah.
And this is scar and this is the polyp, right? All right, so this is what I've done. I basically went in with a hot biopsy so that I can actually take that out to be absolutely sure. And so there's a little bit on the left side, but on the right side of the thing. And we use endocut I, effect 1, and then duration 3. And in interval is set at 3, and it doesn't matter. What matters is your duration and your effect. So, these polyps, although they look small, and when they have a tethered area like that, and you don't take care of it completely, they are likely to come back, and then it becomes a problem each time it comes back. So as you can see, the advantage of having a cap, you can actually use a little bit of water and then get closer to satisfy yourself that you remove the polyp completely. So then we went ahead and did the APC. One thing is important to keep in mind is when you do an APC in the cecum, there is a study that's almost 20 years back from Mayo when they looked at the depth of injury from APC in porcine model with and without submucosal injection of saline. So without submucosal of injection of saline in the cecum, when you apply APC, there is a possibility that you could that thermal injury could get deep and include injury to the muscle. So that is one thing to keep in mind. And that's why when you take care of a patient with AVM in the cecum, and you want to apply APC, it is a good idea to inject maybe a little bit of dilute AP and then apply the APC to the central feeding vessel. And that way you have less damage and you find the feeding vessel. In a case like this, where there is tethering from previous resection, there is already complete obliteration of the submucosa from scarring. And in that case, when you apply APC, this doesn't look good. This doesn't look too bad. But if you leave it open, there is a possibility for delayed perforation. And the second most common cause for perforation is the delayed perforation after APC in the cecum. So something to keep in mind. So any comments on that, Roy, Sylvia, Selby? What do you guys think?
It's beautiful. Clip it.
Okay. All right. So we decided to clip it. And actually, this is a very long clip, actually. I didn't realize that this is so as you can see here, when you apply the clip, you want to make sure that your two blades are deep and you don't have any space between the two blades. So that is very important to keep in mind. And we decided to apply one more clip to just make sure that we have a complete closure. And it's also important to keep in mind whenever you're doing cases that are referred to you, you have to keep in mind, where are they coming from and how far are they? This patient came from almost 5-6 hours away from Houston. All right. So what I actually left it here because, there are lots of points to learn. This was an 8 millimeter lesion that was hot snared in somebody where the endoscopist had a tough time going through the sigmoid colon because of diverticulosis. And I think that's one thing to keep in mind, right? When you have a difficult insertion, your access to the lesion may not be complete or easy. And the second one is the cecal lesion was cut just with a hot snare without submucosal injection. And in a patient with serrated adenoma, you may not realize that the polyp extends beyond what you think that is coming into your snare. And that's probably the reason why there's a residual polyp. Any comments, Sylvia?
I would like to ask a quick question.
Uh-huh.
I don't recall well how many polyps did this patient have cumulatively? I recall 3, so it was the 8 mm, which was resected.
8 millimeter, 10 millimeter, 20 millimeter.
So only 3 lesions.
Right, so far.
Uh-huh. Okay, because my question is, in this situation, a lady in her 60s with serrated polyps in the proximal colon, it's always a question mark for me. Is this a serrated polyposis syndrome? So if she would have two more serrated lesions proximal to the rectum, and 2 of the lesions are already larger than 2 centimeters, then she will fulfill the criteria for serrated polyposis syndrome, which will have impact on the surveillance intervals.
So would you then keep them at every 2 years or 1 year?
I would firstly carefully examine the rest of the colon to make sure whether she fulfills the criteria, whether she has 2 more serrated lesions. So she already has 2 lesions larger than 1 centimeter. If she has in total 5 lesions proximal to the rectum, then this would be a serrated polyposis syndrome. And the surveillance would be indeed 1 to 2 year intervals according to the histology. If the lesions are non-advanced serrated polyps, which means without dysplastic features and smaller than 10 millimeters, then we would go more for 2 years. And if there are dysplastic features, larger lesions, and she has already one of 20 millimeter and one of 10 millimeter, then I would go for 1 year, yearly annual surveillance intervals.
So let me ask you another question. So say, for example, you take care of this patient for the next 5, 6 years, and then during your last year 5 and year 7, you have not seen any polyps. Are you willing to increase the interval to 3 years?
I would review all the reports of such patients. So if she had previous colonoscopies in another center, I will review all colonoscopy reports. And if she had cumulatively more than 5 lesions in the proximal colon, 2 larger than 1 centimeter, or more than 20 throughout the colon, irrespective of size, then I would diagnose her with serrated polyposis syndromes and increase the frequency according to histologic findings.
So as the polyps, as you do the surveillance exams, if the polyp burden becomes less and less,
Yes,
and you have a period like, say, for example,
2
this
years.
year we had 2 polyps, and then 2 years from now, you see no polyps, at that time, what would you do?
I would do 2 year surveillance intervals.
So you're not planning to increase it to 3 years ever?
Well, these are the current surveillance guidelines that we have adopted in these patients.
Right, for sure.
1 to 2 year surveillance intervals, and I think that's a very good question. In my opinion, 1 year surveillance intervals, it's quite intensive because as we compare this patient with a Lynch syndrome, we don't recommend all Lynch syndrome patients who have a much higher risk of cancer, up to 80% lifetime risk. We don't recommend them all to come back in 2 years. In 1 year, only the MLH1, MSH2. And that being said, doing annual surveillance in serrated polyposis syndrome, which has a much lower risk of cancer, is, in my opinion, a bit, well, that's too conservative. Let's put it like that.
Yeah. The reason I'm asking is I'm taking care of a couple of patients, maybe half a dozen patients that I started in the early 2010. And then it's very interesting. They all had a lot of polyps in the initial 5 years, right?
Exactly.
Almost initially every 6 months I had to bring them back to clear them. And then once I clear them, and then they don't tend to form polyps like I expected them to form polyps. So right now I'm keeping them at 2 years. I'm wondering, whether there will be ever a time that if they don't form any polyps, could we safely increase? I still debate myself what to do with them.
I think that there is a clearance phase in the beginning when we aim to remove all lesions larger than 5 mm in size. And sometimes it's not possible if they have in one session. So we let them come back every 6 months until all lesions larger than 5 mm are removed. And then we increase the surveillance intervals to 1 to 2 years, and I think 3 years, it's also okay, according to the findings.
Right.
And an additional advice would be screening of the first degree relatives,
Right.
these patients, starting with age of 45, I guess, every 5 years.
Right.
I think that was one thing I would add is that I would do a chromo on these patients.
Mhm.
When SSA becomes SPS, some of them are the completely flat lesions, which is the 2B lesions. And some of these lesions are so difficult to detect even with chromo.
Yes.
Yeah, I saw one patient yesterday. That was Friday. The guy thought it was a 20 mm lesion, and I had a tough time to figure out. And I sprayed dye, and then I started examining. I could not define this was again in the proximal ascending colon, and I could not define the back border because it was going from one fold to the next fold. So I decided, okay, let's do one thing, let's inject and cut. As we cut, we will define the border. It's a it's a fascinating and troubling experience, I should put it. This was the first time where we struggled, and the problem, another problem was tattoo was injected to define the lesion, and the tattoo made it very difficult to define the border.
Mhm.
Because when you spray dye and then there is tattoo, it's very hard, right?
Yeah.
Right. Shelby, what would you do when you think about serrated polyposis?
Hi, Raju. So I have a few patients that I follow, and I heard your question, and I agree with Sylvia that I would do every 1 to 2 years, regardless of the burden that I find on any given exam. There is a role for genetic testing, although it's not a very definitive test. There's a gene that can be checked for serrated polyposis syndrome, but it's really more of a clinical diagnosis based on the World Health Organization criteria. And the only thing that I would say, I mean, in this particular patient, it didn't look like she had a lot of comorbidities, but if you do have a patient with serrated polyposis syndrome who has a lot of comorbidities, I think obviously, and advancing age, I think those are things that you'd want to weigh into your calculation for to determine the surveillance interval, if you're going to make it any different than what the guidelines recommend. Thank you.
And what's the gene test that you guys do? Is there, is this something that we should ask the patient's family to get it done as well?
In our experience, we don't do any genetic testing. It's just a clinical diagnosis. It has not, at least recommended in current guidelines, do not recommend any genetic testing unless we suspect mixed polyposis syndromes, or there is sometimes an association with nuclei-H associated polyposis, but not currently. And we actually teach our trainees that this is not a genetic syndrome. We just group it together with genetic syndromes to increase awareness.
Right.
But we don't know the genetic cause yet. And I agree with Salve. There is one paper as I recall, showing an association with certain gene mutations, but the level of evidence is low. I don't think that It is in European guidelines. It's not included in the workup of serrated polyposis syndromes.
All right. Any other comments from anybody else? All right. I just see something in the chat. I think Selvi says.
Yes, she sent
Selvi
us
put in an article.
the
Okay.
papers.
All right.
Yes,
Okay.
great.
All right. Let me request Sylvia to summarize the learning take-home message. Sylvia, really appreciate your fantastic messages. Thank you. I'll let you, please do the summary if you could, please.
Thank you so much for this very instructive case. And in short, I think this is a 60 years old lady with multiple polyps in the proximal colon, and the endoscopic features of the lesions make them raise the suspicion of serrated polyposis syndrome. In this case, I would firstly phenotype the lesions by colonoscopy, preferably high definition colonoscopy in combination with dye-based chromoendoscopy. As we know, dye-based increase the detection, the diagnostic yield of small and flat lesions. As Roy mentioned, it's useful in this case to phenotype the lesions at the initial phase because this would confirm the diagnosis of serrated polyposis syndrome. In this case, if the patient would have two more lesions, let's say 5 proximal lesions, 2 of them larger than 1 centimeter, the diagnosis, the clinical diagnosis would be serrated polyposis syndrome. So at the initial examination, we have to remove all the lesions larger than 5 millimeter and keep her under surveillance with 1 to 2 yearly surveillance intervals according to the histologic findings. The resection strategy should be for lesions larger than 1 centimeter, should be EMR because it helps us to better demarcate these very subtle lesions and makes the resection technique safe. I would keep track of all colonoscopy reports over time to make sure whether this is, if the patient has only sporadic serrated polyps, I would keep track of the findings over time to make sure it's not a serrated polyposis syndrome.
Yeah, thank you so much. Beautifully done. Now, one of the things that I started doing maybe in the last year or so is before I do a colonoscopy, I go back and put all the colonoscopy findings, especially the PAT findings together, year by year, whatever, and then enter them into the electronic medical record. So now we use EPIC, that is the electronic health record. And on the front page, there is oncology history. And as part of that oncology history, I include the patient's colon polyp or colon cancers screening and surveillance history all in one place. And that has been very helpful because when you try to take care of patients for a long haul, you will miss if you don't have all the data at one place. So that is something I find it very useful, but it takes time, to do that,
And recall systems in place, recall systems to make sure that these patients get surveillance according to the guideline recommendations.
Right.
But then it's indeed, you need additional support, and a student or a nurse, a practitioner may help in these situations. I think it's very useful to have them
Right.
in the
Right.
team.
Ravi,
I
any
think
comment?
the other thing that people often miss is the family history and the possibility that the patient actually has a syndrome, especially the Lynch syndrome.
Mhm.
So if it's like listed in your family history, I think it should be looked at. I kept seeing in my practice with the trainees that they have no understanding whatsoever that the family, what the family history is, may actually be part of Lynch. And you know, the patients could come back at the wrong time interval.
Yeah. Yeah, it's very interesting. Even if somebody has no family history, I just want to make a point here. That is, if somebody comes in and gets their screening colonoscopy at 45 or 50, whatever it is, and you don't find any polyps and you recommend colonoscopy in 10 years, as part of my recommendation, I tell them in 5 years, reevaluate your risk by reviewing your family history. And I started doing that almost, for the last several years. And I had at least 2 patients who came back and told me that, hey, one of my family member was diagnosed with colon cancer, right? If there's a family member with colon cancer, then the surveillance intervals change, not 1 in 10 years, because he becomes high risk patient and it should be at 5 years. So to keep that thing in mind, and that is part of my recommendation automatically. If I click 10 years, automatically it will also pick up, reevaluate your risk at 5 years.
That's
So
very
something to keep in mind as we take care of patients with colon cancer.